Amy, can you see the screen and hear me?
Yes.
You're good to go.
Great. All right. Good afternoon, everyone. I apologize for the technical difficulties. There was some disconnect between Zoom and government addresses, so I apologize for that. But I'm really excited to be here this afternoon, be able to share a little with you about substance use disorder treatment. My name is Karran Phillips. I am currently the acting director for the Center for Substance Abuse Treatment at SAMHSA, part of HHS. And this is the final week of Substance Use Disorder Treatment Month. I hope you all have had an opportunity to take a look at all of the wonderful things on the website regarding graphics, social media posts, and a variety of other content. We are going to wrap up the month with a second webinar tomorrow, which will be a fireside chat between Angela Caldwell and David Adewale, both from SAMHSA, one in CSAT and one in the Office of Recovery, with an introduction and moderation by Berlina Wallace-Berube. And they are going to talk about different pathways to recovery. So without further ado, I'm going to go ahead and get started. My goal for this afternoon is pretty broad. So we're not going to go deep here. We're going to go broad. And my hope is that we can cover some of the definitions and risk factors, take a look at the most recent data from NISDA and other sources, talk a little bit about stigma, go into treatment options, both behavioral as well as pharmacological, and then give an opportunity for me to talk a little bit about CSAT and SAMHSA and our work around MOUD and substance use disorder treatment, and then provide you all with resources. So to start, substance use disorder, just so we're all on the same playing field. It's a chronic relapsing disorder. It's characterized by compulsive drug seeking, continued use despite harmful consequences, and long-lasting changes in the brain. This is a chronic disease. It should be approached and treated and managed just like all of our other chronic diseases, whether it be hypertension, diabetes. And that means that there are ebbs and flows to the treatment, that different modalities need to be used, that needs to be monitored and changed on a regular basis. And not the same thing works for all individuals. So just some things to keep in mind as we work through. So I don't want to get too much into the neurobiology, but I do want to at least share this slide that looks at addiction and substance use disorder from a multifactorial standpoint. We know that biology and genes play a role in addiction. We know that there is genetic predispositions up to over 50% in some conditions like alcohol use disorder, that our sex plays a role. Men and women are affected differently. And the co-occurrence of mental health disorders has an impact. In addition to our biology and genes, there's an environmental impact. And this can be a micro environment or the macro environment. So the micro environment might be adverse childhood experiences. It might be the family or community you grow up in. And it might be more macro environmental factors as well. I think then we have the drug itself. The drug, depending on which drug is being used, it has its own pharmacokinetic and other impacts. And that can be related to the route of use, the potency, their duration of effect. And all of these factors play into addiction being a chronic disease of the brain and have impact on brain mechanisms. And they cause neurological changes in our brain along the lines of the neurotransmitters and the availability of those and the levels of those, our ability to release dopamine, and how all of these drugs are impacting the reward system in our brain. The reward system neurotransmitter is dopamine. When we take these drugs, our dopamine levels go up, and they go up higher than dopamine does for natural rewards. So the reward system works on our natural rewards like food, sex, music, and we experience dopamine increases in all of those activities, but those are dwarfed by the amount of dopamine that is released when individuals use drugs. And that is why a lot of individuals will get to the point where they are not using drugs for the euphoric effect or for the amnesic effect or any other effect. They just need to use drugs to what they say to feel normal because their brain is so flooded with dopamine that those natural rewards and those lower levels of dopamine cannot compete with the high levels that folks experience when they use drugs. So let's move on a little bit to the pervasiveness of substance use. We'll start with the overdose. I mean, the good news has been that overdose deaths are on the decline, but you have to take that with a grain of salt because there are still over 73,000 lives lost a year to opioid use, or to opioid use and overdose. Sorry, I advanced that too fast. And so looking at the figure here on the right, you can see the black line is reflecting all opioids. The brown line is synthetic opioids. The green line is natural and semi-synthetic opioids, and the blue line is heroin. With all of these opioids, you can see that the decrease in overdose deaths appears to be related to a decrease in synthetic opioid overdoses. Um, Also notable on this is the purple and gray lines, which are, or I should say pink and gray lines, which are cocaine and psychostimulants. And notable here is that that is not really decreasing. So we still have a psychostimulant and stimulant addiction epidemic going on in at the same time as our opioid epidemic. And then the slide in the bottom left, the map. So I think the striking thing here is, again, it does indicate that the predicted percent change in overdose deaths in the United States would be a decrease by almost 25%. But what's notable here is the difference, the geographic difference, and how that is not something that's happening universally across the United States. The states in orange here actually represent states where there is a predicted increase of almost 10% in overdose deaths. The darker blue indicates the decrease. And then, of course, the light blue is a decrease, but to a lesser extent. So the geographic sort of disparities for overdose are very notable. And I think that while some communities are absolutely seeing a decrease, others are not and are actually continuing to show, unfortunately, an increase in opioid overdose deaths. Also, I think it's really important that we remember how risky our drug supply has become. With the advent of individuals who can, be basement chemists, or who can create some of these synthetic analogs and drugs with very few ingredients or ingredients that are readily available and can do so in their basement. Becomes a real risk for our patients and our communities where drug use is prevalent. The pictures on the upper left here show that there is an increasing um, production of fake pills. And you can see in the top, there's some real Adderall pills, the dark orange, and the fake pills in the lighter orange. And it is really hard to tell the difference. The bag to the right with the multicolored tabs are actually MDMA, and these were found to be contaminated with methamphetamine. Other emerging drug trends have also been really notable and scary. You can see from the figures, we've got carfentanil, which is a synthetic analog of fentanyl and almost 1,000 times more potent. And you can see a significant increase in carfentanil over the last few years. Another drug that we've seen increasingly is medetomidine. This is a veterinary sedative that has been cut into the drug supply and has is been used with sedating large animals. And so even small doses can be really impactful on humans, causing its own symptoms of not only use, being sedation, decrease in blood pressure and heart rate, but then also symptoms of withdrawal, where individuals have been had medetomidine cut into their drug supply, and when they stop using or reduce their use or use drugs that may be cut with something else or nothing at all, they experience a withdrawal from medetomidine. And that can be all those reverse effects. It can be elevated blood pressure, elevated heart rate, anxiety, tremors, and can be really, really dangerous. And then the table here just shows you a sample of many of the drugs that we find cut into adulterants that we find cut into heroin and cocaine, and how they each have their own possible clinical effects, whether it be liver failure, increased heart rate, respiratory depression, seizures, renal failure. It really runs the gamut. So the drug supply is riskier than it ever has been. I did want to share a little bit of the NISDA data, and this is the most recent data. It was published last year, and strikingly, 48.4 million people 12 or older have had a substance use disorder in the past year. Almost 28 million with an alcohol use disorder, 28 million with a drug use disorder, and 8 million with both an alcohol use disorder and a drug use disorder. And when we look at individuals classified as needing substance use treatment in the past year, that's 1 in 5. It's almost 20%. That's 10 million people who've received substance use treatment in the past year. But that also means that there are 4 in 5 that did not. And I think we're going to talk a little bit more about that. So this just looks at individuals who newly started using substances. So this is no previous history, and this is their initial or first use. And it's the number of initiates in the year 2024. And then it's broken down also by age on the other figure. And so you can see nicotine and vaping is the most frequently newly used drug, followed by alcohol. You can see marijuana. And then as you go down, you get into some of the hallucinogens, the stimulants, and the opioids. And if we look at this breakdown by age, being 21 and older or first use before age 21, you can see that 70% of individuals who are using alcohol for the first time are doing so under the age of 21. 52% of folks using marijuana are doing so under the age of 21. So this is certainly something that affects all age groups and youth in particular. And because of the neurobiology and the developmental sort of process with youth, whose brains and specifically frontal cortex are not fully developed often until their early to mid 20s, you can see where initiation of these substances at an early age can be very problematic and may have implications, and increasingly have been shown to have implications in on the developing brain. This just looks at past month substance use, and again, alcohol and tobacco and nicotine being the most common, but with marijuana also quite high as well. And then this looks at past year use, and the trend being similar, with over 73 million individuals, and 25% of the population with some sort of past year illicit drug use, with marijuana being the most common among those. So I want to sort of move into talking about treatment more, and that's going to be really our main focus moving forward. So this graph shows people who needed and received substance use disorder treatment in 2024, ages 12 and over, or older. And this includes treatment for drug or alcohol use in an inpatient setting, an outpatient setting. And it can include medications for alcohol use disorder, medications for opioid use disorder. It might be in a telehealth setting, and it might be in a criminal justice setting. And so we can see here that 20% of individuals 12 or over. And then when we break it down by age, 30% in the 12 to 17, that 18 to 25 age range having some of the lowest past year substance use treatment numbers, and then of course 26 and older. This slide just talks a little bit about the variety of treatment options that do exist, or treatment settings that exist, whether it be inpatient, outpatient, telehealth, and then also a little bit about sort of specifically medications for opioid use disorder, or MOUD, medications for alcohol use disorder, MAUD, and criminal justice. So this looks at the number of people receiving substance use treatment in the past year. For 2024, that was a little over 10 million, the majority of whom receive it in a outpatient setting. Increasingly, people are receiving it in a telehealth setting, and that largely has to do initially with the COVID flexibilities about the ability to initiate and continue to prescribe MOUD that were in place for the COVID time period. And now those telehealth flexibilities have been extended. And telehealth creates a very safe and effective way to extend the ability to treatment to a wider range of individuals, particularly in perhaps rural areas where access to treatment in person in an outpatient or inpatient setting may not be as readily available. So this advent of telehealth treatment is really has the potential to continue to expand access to substance use disorder treatment, which is a great thing. So the challenge. So the challenge is that the data shows millions of Americans live with alcohol and or alcohol use, with opioid and or alcohol use disorder, but only a fraction are receiving evidence-based treatment, less than 15% with opioid use disorder and less than 1% with alcohol use disorder. We know that medications save lives. We know they're evidence-based. We have FDA approval for these medications, yet they remain underutilized for treatment. And so what are some of those reasons, and what can we do to address that? So stigma, it's a huge reason why treatment and medications for substance use disorder are underutilized. And it can occur at many levels. It can occur at the level of the provider, the community, the institution. It can be at the level of the treatment center and the individual themselves. And we know that people with substance use disorder are less likely to seek treatment and more likely to drop out of it. It is SUD is one of the most, if not the most, stigmatized condition, not only in the US, but around the world. And healthcare providers treat patients who have substance use disorder differently. And people with substance use disorder who expect or experience stigma have poor outcomes. So, stigma is not only an issue in individuals accessing treatment, it's also an issue of individuals staying in treatment and an issue impacting negatively individuals' outcomes in treatment. So treatment is prevention. So again, with this theme that opioid use disorder is a chronic disease, like high blood pressure, like diabetes, like heart disease. And when we treat those chronic diseases, we need to use multiple tools. We are very fortunate that for many of them we do have multiple tools. So for hypertension or high blood pressure, we may ask folks to engage in behavioral modifications, to lose weight, to exercise more, decrease salt in their diets. We may ask them to take medications, and we have numerous medications. What we don't do is tell them that they can take the medication for 6 months and then we're going to taper them off, regardless if they're doing well or not, which we still see in opioid use disorder. And I think we are fortunate with opioid use disorder that we do have 3 FDA approved medications, which we'll talk about a little bit more in a minute here. And these are effective treatments, and we know that they reduce the risk of overdose, and we know that they create opportunity for individuals who've experienced overdose to make positive changes in their lives. And so just like with other chronic diseases, we should approach our patients with substance use disorder with a multimodal approach. And so that can include lots of things. And I don't by any way mean to make this slide seem completely inclusive of all opportunities. But in regards to medications, we do have 3 FDA-approved medications: methadone, buprenorphine, and naltrexone. In regards to counseling and peer support, there are many different counseling modalities. I list a few here: motivational interviewing, cognitive behavioral therapy, contingency management, and of course, peer support. So this is individuals with lived experience who provide non-clinical support, which has been shown, along with the behavioral therapies and the medications, to be highly effective in creating positive outcomes for individuals with substance use disorder. And then, of course, social support. And this goes towards the importance of sort of a recovery-focused treatment approach that looks at a patient-centered approach. It looks at the whole person and wants to ensure things like a safe place to live, access to healthy food, employment, income, education, transportation. And again, this list is by no means exhaustive, but what I really want to point out here is that as our Substance Use Disorder Treatment Month graphic here shows, there's no one size fits all. Different treatment options work with different people, for different people, I should say, and it's a matter of finding the one that's right for you. So behavioral therapy, again, just touch upon this briefly, but there are many types of therapy and counseling. They are often part of individuals' treatment plans. Usually, they are being provided by a licensed behavioral health professional, and they can occur in a variety of settings. And I will say that there are these QR codes on several of these slides. And if utilized, you will find that they link to the appropriate resources. So this QR code links to behavioral health therapies for substance use disorder. Contingency management, I did want to mention, this is where we use motivational incentives for people when they achieve outcomes, desired outcomes in their substance use disorder treatment. So it may be that an individual attends 10 out of 10 of their group sessions, and then they're given a motivational incentive. And it could be a spin on a wheel where they are, the different pie pieces of the wheel might be a pair of socks, a book, $5 voucher to McDonald's, or a variety of things. And there are other sort of strategies or approaches to how contingency management can be used. It is an evidence-based practice, and we are continuing to look at how we can make it more accessible to folks working with individuals with substance use disorder. So just briefly on the medications for opioid use disorder. So we've talked a little bit about the behavioral interventions. Now I'm talking about some pharmacological interventions. We have 3 FDA approved: methadone, buprenorphine containing products, and naltrexone containing products. You can see they come in a variety of formulations. Some are taken twice a day, some once a day, some are an injection once a week, some are once a month. And you can see here that most of them are available in opioid treatment programs. Methadone can only be dispensed in an opioid treatment program, or in some instances, hospitals and long-term care facilities, as well as correctional settings with the appropriate DEA designations. Buprenorphine can be dispensed in an office-based setting or in an opioid treatment program. And of course, there is no longer a waiver required for buprenorphine administration or prescribing. There is just a requirement for a one-time training and some DEA registration. And then naltrexone, also available in both settings, office-based and opioid treatment programs. So this is a little bit on medications, a little bit more in the, I guess, pharmacology or neuropharmacology of medications for opioid use disorder. And as I mentioned, the 3 medications we have, they work slightly differently. You have methadone, which is a full agonist, buprenorphine, a partial, naltrexone, an antagonist. And so basically the way these work is there's 2 main characteristics of the medications that we look at. One is the binding affinity. So we have opioid receptors in our brain, in our central nervous system. And when we take any of these medications, or if we use heroin or fentanyl on the street, those substances bind to the opioid receptor, specifically the mu opioid receptor, and that triggers a cascade of events, including the release of dopamine, that then has the therapeutic effects in the case of these medications, and other effects in the case of heroin and fentanyl in regards to analgesia, euphoria, amnesia, etc. And so the binding affinity is how tightly that medication binds to the opioid receptor in the brain. And then the intrinsic effect is how much it impacts sort of that dopamine and release. And I think that looking at those 2 characteristics is how we differentiate a full agonist, which has both high binding affinity and high intrinsic activity, a partial agonist, which has high binding affinity but a lesser intrinsic effect, and then an antagonist, which does the opposite of the agonist. Or is a blocker, I should say, of the receptor. And the differences here result in a little bit of difference in how the medication should be prescribed and the safety around them. So there is a ceiling effect with the partial agonist because of its decreased intrinsic effect, which means that the risk of overdose from buprenorphine tends to be lower as it acts as a partial agonist. Oops. No. And this is just sort of showing how um, these different receptors attach to the substances attached to the receptors. So there's great evidence for medications for opioid use disorder. They all of them reduce craving, misuse, increase treatment retention and recurrence. And then additionally, buprenorphine and methadone reduce overdose, treat withdrawal, reduce infectious disease, reduce mortality, increase employment, and are available for use in pregnancy. And methadone also has been shown in several studies to reduce criminality. And so this is really strong evidence for medications for opioid use disorder. And I do have two pictures here of some of SAMHSA's publications related to medications for opioid use disorder, if you're interested in more information. I also just want to point out that treatment with these evidence-based, and there's a typo there, it should be FDA-approved medications, is not addiction by another means. So when individuals who might say things like, "Oh, well, you're not really in treatment because you're using methadone, and methadone is just an opioid." This is an FDA-approved medication that is prescribed by a licensed provider, which is, again, very similar to chronic disease, other chronic diseases, and therefore should not be considered in any way addiction in its own right. So now I'm going to move a little bit into CSAT and the Center for Substance Abuse Treatment and sort of our goals and working and the work that we do. So really the main goal is to connect people to treatment. And the way that we do that is by promoting community-based substance use disorder treatment and recovery support systems for individuals, families, and communities. We do this with a lot of collaboration with other state and federal agencies, and the goal is to expand access to treatment. All right. So more on expanding access to treatment. One of the ways that SAMHSA and CSAT help to expand access to treatment is through our opioid treatment programs, which SAMHSA certifies. This map here shows you the distribution of opioid treatment programs in the United States, as well as some of the Pacific jurisdictions. And you can see that they are well represented, except for the state of Wyoming, where there are no opioid treatment programs. This data is as of December of 2025. There were a total of 2119 across the country. But again, we were looking at that geographic distribution previously of overdose deaths and how it was not equal across the United States. Here, too, we see access to treatment is not equal across the United States. Whereas some states, as large as Montana, may only have 4 opioid treatment programs. So you could imagine that an individual who wants to receive methadone in Montana may live several hours away from the closest opioid treatment program, which is obviously problematic because methadone, at least initially, individuals will start out taking is directly observed therapy almost on a daily basis, and then hopefully they can progress into less frequent attendance in person and they get take-home medications. But if you're traveling 8 hours to your closest OTP, that is not a viable solution and is not adequate access to um, addiction treatment. And so we still have a ways to go here. The other way that we expand access is by integrating physical and behavioral health care. And this allows us to address some of the stigma. When we create a situation where, again, substance use disorder is considered is considered like any other chronic disease. And we might even be treating it in conjunction with the other diseases, either in a co-located setting or through referral. The integration of physical and behavioral health care helps to destigmatize um, substance use disorder treatment and allows us to increase access. I did want to point out some funding that SAMHSA released at the end of last fiscal year in September of 2025. This is a $98 million hepatitis C elimination initiative pilot. So the key here is that individuals who have substance use disorder, mental illness, and or co-occurring disorders, who are being asked, or as part of this program, are being screened and treated to cure hepatitis C. And we have 19 grantees across the United States, including tribal entities, and they are receiving a 2-year grant for 2.5 million to 7.5 million dollars each. And we're really excited about this program. You can find out more about it with the QR code. And again, this is seeking to address increase access to substance use disorder and mental health treatment while also addressing hepatitis C. Another way that CSAT and SAMHSA seek to expand access is by providing person-centered care. And that means providing care that is really looking at the individual and all of the different factors that impact their ability to be in treatment and to stay in treatment and to thrive in treatment and recovery. And one of those things is we looked at that figure before, we kind of talked about medication and we talked about behavioral supports, and then we talked about those social supports. Housing is a huge issue for a lot of individuals with substance use disorder. And there's strong evidence that a stable housing situation allows for individuals to engage more completely in treatment and recovery. And we also saw from some of the maps and figures earlier that youth in particular perhaps are experiencing high levels of substance use disorder and having significant treatment gaps. And so this is through our state opioid response program, and it is specifically a youth recovery housing project. Again, funded at the end of last fiscal year. It's over $45 million that goes to several states and territories where the focus is specifically for developing sober recovery housing among youth with substance use disorder. So I wanted to talk a little bit about expanding access by strengthening the treatment workforce. We have a wonderful coalition called the Addiction Technology Transfer Center Network, or the ATTCs. They are in 10 regions, and then there is a national network coordinating office at the University of Missouri in Kansas City. They do incredible work, and it is very um, focused on sort of the needs of their regions. As you can imagine, the needs are different in Maine than they are in New Mexico. And the regional ATTCs allow for sort of the very specific community focused technical support. So they support not only workforce development. So if we are going to improve access to substance use disorder treatment, we need to have individuals who are willing to work in substance use disorder treatment. They need to be well educated. They need to be well trained. They need to be well reimbursed. And ATTCs do a tremendous job uh, creating that workforce and strengthening it, among many other things. The ATTCs do. And again, please be sure to connect with them using the QR codes. Another technical assistance program is our opioid response network. This is also this is a coalition of hundreds of organizations focused on really community education and training. And it's not just that this education is provided, but it's really driven by the community. So it's a bottom up sort of responsive approach to providing what a specific community needs. They do trainings on stigma and substance use disorder implementation as well as workforce. So it's an incredible resource and again, available nationally. Education and training of our providers, as mentioned before, is hugely important. And we tried to provide as much support to providers through our clinical support system. It's a national training and technical assistance initiative. It's focused on SUD treatment. There are a variety of resources about evidence-based medications, behavioral therapies, billing questions. I mean, it runs the gamut, and it really tries to support their workforce in any way they need in order to be able to provide quality substance use disorder treatment. Here, I just wanted to show that there are additional practitioner training opportunities that SAMHSA supports. In addition to the PCSS, there's a Rural Opioid Technical Assistance program. There's the Opioid Response Network, as mentioned. There's the Strategic Prevention Technical Assistance, or SPTAC, and a variety of other programs to help support the substance use disorder and mental health workforce. In addition, SAMHSA and CSAT try to make sure that we are getting timely products out into the community. In 2025, SAMHSA was able to publish 2 documents, both of which were designed to hopefully increase uptake and provision of MOUD in carceral settings. There were the guidelines for opioid use disorder treatment in state prisons, as well as the clinical considerations for methadone treatment in correctional facilities. And so making sure that we reach as many communities, populations, and groups as possible, particularly those ones most affected by substance use disorder, is obviously our goal, and increasing access to treatment within the carceral and system is part and parcel of that. I did want to mention tip 63. It was published back in 2021. A lot has happened, and so we are working on a update to this, the second revision, and we are hopeful that will be available soon. And here I'm just listing a bunch of additional SAMHSA resources that may be useful to all of you who are seeking to increase access to substance use disorder treatment. These are all part of our evidence-based practice resource center. I'm listing just the ones related to substance use disorder, but of course, there are publications in the EBPRC that cover suicide and crisis, as well as serious mental illness. So I encourage you, if you have the time, to take a look at some of the offerings. And so as I wrap up here, I just wanted to put in a plug for the findtreatment.gov. This is sort of a screenshot of what it looks like. Individuals can put in a zip code or a facility or a city, press search, and we'll get a list of a variety of different behavioral health treatment facilities. So it includes mental health treatment, substance use treatment, and as well as some co-occurring disorder or treatment and sometimes primary care as well. But mainly that it is a treatment facility finder for behavioral health, both mental health and substance use disorder. And with that, I want to thank you all and put in my plug for Substance Use Disorder Treatment Month. This is the second time we've hosted it. We are very thrilled that we were able to continue it this year, and that's in large part thanks to the support from all of you. We do hope to be able to continue this annually, and we do hope to continue to grow it and to make sure that you all are getting the information, resources that you need in order to continue the fantastic work that you all do around substance use disorder. So thank you all, and that concludes my talk.